All right, let's jump straight into this explainer because we are tackling a massive, massive target in healthcare compliance today. We're talking about why elevated cardiac troponin levels are basically a homing beacon for payers, recovery audit contractors, and clinical validation teams. You know the drill. When a health record boldly states acute myocardial infarction but completely lacks the objective ischemic evidence to back it up, it immediately raises red flags. So today we are going to break down exactly how to navigate these incredibly complex clinical scenarios using the 2026 AHIMA and ACDS guidelines.
Here's what we're covering. First, the clinical validation dilemma. Then, the 2026 compliant query standards, extracting key clinical indicators, structuring the validation query, and finally, defending the health record. Let's get into it.
Section 1. The clinical validation dilemma.
Consider a cardiology consult note that states, mild cardiac enzyme elevation, suspect possibly secondary to volume depletion, and mild heart strain. This perfectly illustrates the daily dilemma CDI teams face. Now, we know the fourth universal definition of myocardial infarction requires a specific clinical picture, right? You need a rise and fall of troponin with at least one value above the 99th percentile upper reference limit, combined with clear clinical evidence of ischemia. But here, a provider is just noting suspected mild heart strain from volume depletion. So is this a true type 2 MI driven by a severe oxygen supply and demand mismatch, or is it simply a non-ischemic myocardial injury? The ambiguity here is an absolute compliance nightmare.
This is where clinical validation comes in. When a diagnosis is floating in the chart without solid anchor points, like, say, calling a mild troponin leak an acute MI without any mention of ischemic chest pain, ECG changes, or imaging abnormalities, we absolutely must initiate a clinical validation query. Listen, we aren't here to play armchair doctor or negate a physician's clinical judgment, but we do have to ask them to validate that judgment with objective data before an auditor happily swoops in and reclaims the hospital's money.
Moving to Section 2, 2026 Compliant Query Standards.
So what actually makes a query compliant? Well, it boils down to a few absolute non-negotiables. The communication has to be strictly non-leading. It must rely on clinically relevant sourced indicators from the current encounter. You can literally never, ever include references to reimbursement, quality metrics, or financial impact. And above all, the query must offer the provider an entirely uninfluenced opportunity to exercise their independent clinical judgment.
A classic pitfall happens right in the query title. Think about how your electronic health record alerts a provider. If the subject line says, "Query for acute MI," you've just planted a leading diagnosis in their mind before they've even read the clinical facts. That's a huge violation of the guidelines. Something like CDI provider query, cardiac status, is neutral, it's compliant, and it sets the proper, unbiased foundation.
Section 3. Extracting key clinical indicators.
Let's walk through a real-world case. We're extracting objective data for a 73-year-old patient, MS. What do we actually have? We've got a mild troponin elevation of 0.17 against the chronic baseline of 0.09. We see ST segment depressions? Sure. But the chart notes they're unchanged from previous EKGs. Notice what is blatantly missing here. No new T-wave inversions, no new left bundle branch block, no coronary angiography findings, and no cardiac imaging showing a new loss of viable myocardium. What we do have is a 4-day history of severe nausea and vomiting leading to volume depletion alongside a mildly elevated AST.
So what are we actually looking at here? Do these specific indicators point to a true acute MI? Is this a type 1 MI caused by an atherosclerotic plaque rupture, ulceration, or coronary thrombus? Or are we looking at a type 2 MI caused by a severe supply and demand mismatch, which we typically see in severe shock, severe anemia, or acute respiratory failure? Given the old ECG changes and the relatively mild troponin bump, could this just be acute demand ischemia without an actual infarction? Or perhaps it's a non-ischemic myocardial injury driven purely by the severe gastroenteritis.
Section 4. Structuring the validation query. To bridge the gap between a vague note about mild heart strain and a concrete validated diagnosis, we have to rely on a very strict 3-step process. Step 1. Cite exactly where the evidence lives in the chart, like cardiology consult dated August 4th. Step 2. Present the objective indicators exactly as they are written. And Step 3. Provide a multiple choice list that covers the entire spectrum of clinical possibilities.
And this brings us to a golden rule in the 2026 guidelines. You cannot insert your own clinical interpretation.
If the record states a heart rate of 120, we just list 120. We don't independently label it as tachycardia in our query. If the troponin is 0.17, we simply state troponin 0.17. We never say infarction level troponin. We provide the raw objective data, completely without bias.
When it comes to your multiple choice options, they have to be comprehensive, and they absolutely must include other and unable to determine. By offering options like acute myocardial infarction, demand ischemia, and non-ischemic myocardial injury side by side, you allow the physician to pinpoint the exact pathology. Did necrosis occur due to that severe supply/demand mismatch, making it a type 2 MI? Is it just acute demand ischemia with ischemic chest pain but no infarction? Or is it a non-ischemic myocardial injury, maybe from sepsis or acute heart failure? The choice has to remain entirely in the physician's hands.
Section 5. Defending the health record.
Why are we being such sticklers about this? Because when the provider answers a compliant query and authenticates it in the permanent record, it establishes the clinical truth of that encounter. The guidelines explicitly state that a provider's response represents their clinical judgment at the time of documentation. If you built that query compliantly without leading them, external reviewers and RAC auditors cannot easily dismiss the provider's clinical determination.
The stakes here are just huge. Differentiating a true STEMI or NSTEMI from demand ischemia or chronic myocardial injury dramatically impacts everything. For instance, a type 2 MI acts as a major complication or comorbidity, an MCC. That classification drastically shifts your MSDRG assignment and your risk-adjusted mortality models. Non-ischemic myocardial injury simply does not carry that same weight. Validating the exact diagnosis ensures precise severity of illness and risk of mortality scores, keeps cardiac quality metrics accurate, and builds an ironclad defense against those crippling payer denials.
So as you review your own organizational practices, I really want you to ask yourself, do your queries truly hold up to this standard? Can they actually withstand the scrutiny of a ruthless audit? Ensure your clinical indicators are airtight, keep your formatting strictly neutral, and always leave the power of diagnosis exactly where it belongs, with the physician. Thank you so much for joining me for this explainer, and remember, please like, share, subscribe to Decode Healthcare with Harshal.